Okay, it's time for part 3 of TBI and GCS scale from the O'Sullivan book. I already did the O'Sullivan book, so now it's time for therapy ed. Right? Yes, therapy ed. We've already done the previous slides on part 1 and part 2, so let's get into therapy ed. Traumatic brain injury, etiology. Mechanism of injury is contact forces to the skull and rotational acceleration forces, causing varying degrees of injury to the brain. Localized lesions of the cortex, see table 212. We're going to get into that in a little bit. Pathophysiology. Primary brain damage is diffuse axonal injury, disruption and tearing of axons and small blood vessels from shear strain of angular acceleration, results in neuronal death and petechial hemorrhages. Focal injury, contusions, lacerations, mass effect from hemorrhage and edema, hematoma. Contra coup injury, injury at point of impact and opposite point of impact. And then, of course, we have closed or open injury with fracture of the skull. So, pathophysiology, primary brain damage, diffuse axonal injury. So, let's see. Pause this for a second. Okay, so categories of traumatic brain injury: focal brain injury, diffuse brain injury, and skull fractures. Pathophysiology, primary brain damage, diffuse axonal injury, diffuse brain injury, a contusion, or diffuse axonal injury. Disruption and tearing of axons and small blood vessels from shear strain of angular accelerations results in neuronal death and petechial hemorrhages. Focal injury, contusions, lacerations, mass effect from hemorrhage and edema, like a hematoma. Contra coup injury, injury at point of impact and opposite point of impact. An enclosed or open injury with fracture of the skull. So, diffuse axonal injury, one of the primary brain damage is a widespread damage to axons in the cerebral hemispheres, corpus callosum, and brainstem. Can be seen in mild, moderate, or severe head trauma and results in axial swelling and disconnection. So here's your petechial hemorrhages right here. That's what that looks like. The focal injuries, which is contusions, lacerations, and mass effect from hemorrhage and edema, which is a hematoma. So epidural hematomas come from bleeding between the dura and the inner surface of the skull. The patient will be unconscious, then awake, and then deteriorate. Headache, nausea, and vomiting, and need surgical intervention to prevent brain herniation and death. The contusion is bruising of the brain tissue, has area of necrosis, infarction, and hemorrhage, often from a contra coup injury, and seizures are common after a contusion. Then we have the counter coup injury. The damage may occur directly under the site of impact, which is the coup, or it may occur on the side opposite of the impact, which is the counter coup. And then mechanism of a closed head injury, that would be a coup counter coup. That's an example of a closed head injury. And I like this picture because it shows the anatomy of the brain, and I'm an anatomy nerd. It shows higher mental functioning. It shows motor functions in gold, the more motor functions in blue, sensory functions, associative functions, visual functioning, speech functions, auditory functions, association functions, emotional functions, sensory association functions, olfactory functions, and more, some cerebellar. So the top are cerebral and then cerebellar functions. And here are the types of skull fractures: open, closed, or open injury. So with a counter coup, you could probably get a skull fracture, which would be a closed head injury with skull fracture. Subdural hematoma. What is the EDH? Hemorrhage. No, it's a hemorrhage. A depressed fracture with a focal parenchymal lesion. Skull base fracture, and then open head injuries like a knife, firearm laceration of the dura. Okay, so then we're to the secondary brain damage, which is hypoxic ischemic injury. It results from systemic problems such as respiratory or cardiovascular problems that compromise cerebral circulation. Another secondary brain damage effect would be swelling and edema. Can result in mass effect with increased intracranial pressures, ICP, brain herniation, uncal, central, or tonsillar, and death. Another secondary brain damage effect could be electrolyte imbalance and mass release of damaging neurotransmitters. And then so yeah, primary brain damage. This is the pathophysiology. Primary brain damage. Secondary brain damage is number 2. And number 3 is contusion. Concussion. Sorry, can't read this morning. Concussions. Let's go back. Right. Primary brain damage, secondary brain damage, and concussion. Loss of consciousness, either temporary or permanent, resulting from injury or blow to the head, with impaired functioning of the brainstem, reticular activating system. May see changes in heart rate, respiratory rate, and blood pressure. Why do I feel like I'm... Let's see, DE. No. C. Okay. So C was pathophysiology, and D is levels of traumatic brain injury. See table 313. E is standardized test, outcome measures for patients with traumatic brain injury. Also see Appendix 2A. So starting with the Glasgow Coma Scale, GCS examines eye, verbal, and motor responses. Eye, verbal, and motor responses, allows classification into mild, score of 13 to 15, moderate, score 9 to 12, or severe, score less than 8, head injury. And we talked about that in a previous, we talked about that up here. We'll go ahead and copy paste that. Why not, right? Pictures are wonderful. Awesome. Love me some pictures. Okay. There we go. Okay, so the Glasgow Coma Scale, mild, 13 to 15, moderate, 9 to 12, severe, score, less than 8. Duplicate and delete. Okay, and then we have the Rancho Los Dominguez level of cognitive functioning. Delineates 8 general cognitive and behavioral levels. And again, we went over that in the previous video in detail. I had a lot more energy yesterday when I did that. I don't know why I'm so tired today. Probably like kickboxing I've been doing. Trying to get in shape. There we go. Okay, so there it is again. 3 responses, 3 confused, and 3 appropriates. No response, general response, localized response. Confused, agitated, confused, inappropriate, confused, appropriate. And then we have confused, appropriate, automatic, appropriate, and purposeful, appropriate. So look at part 2 if you want to listen to me talk about that in more detail. Rappaport's disability rating scale classifies levels of disability using a wide range of functional behaviors. Glasgow Outcome Scale examines cognition, behavior regulation, home management, community function, work, and leisure recreational abilities. Outcome Scale. High Level Mobility Assessment, HIMAT, see previous discussion, and Functional Independence Measure and Functional Assessment Measure. Those were talked in detail. I'm pretty sure this one too. But 4, 5, and 6 I know for sure was in the reading. So that would be part 1 of 3. So this is the 3rd part. So if you want to hear more about these 3, revisit part 1. And then we have more. Neurological Outcome Scale for Traumatic Brain Injury stratifies for injury severity and demonstrates progress of TBI interventions. Assessment of Life Habits examines participation in ADLs, health and wellness, community function, leisure recreational activities, life satisfaction, quality of life, work, and social activities. Coma Recovery Scale, revised, examines cognition, somatosensation, and responsiveness to auditory, visual, motor, oromotor, communication, and arousal. Moss Attention Rating Scale examines cognition and moderate to severe problems with attention. So the book really explains those a little bit more than this therapy aid. So revisit part 1. Recovery stages from diffuse axonal injury. Coma, a state of unconsciousness in which there is neither arousal or awareness. Eyes remain closed, no sleep-awake cycles. 2. Unresponsive vigilance vegetative state, marked by the return of sleep-wake cycles and normalization of vegetative functions such as respiration, digestion, and blood pressure control. Persistent vegetative state is determined if patient remains in vegetative state greater than 1 year after TBI. Mute unresponsiveness, minimally responsive. State in which patient is not vegetative and thus shows signs, even if intermittent, of fluctuating awareness. Confusional state, mainly a disturbance of attention mechanisms. All cognitive operations are affected. Patient is unable to form new memories, may demonstrate either hypoarousal or hyperarousal. 5. Emerging independence. Confusion is clearing and some memory is possible. Significant cognitive problems and limited insight remain. Frequently uninhibited social behaviors. 6. Intellectual social incompetence. Increasing independence, although cognitive difficulties in problem solving and reasoning, and persist along with behavioral and social problems, such as the enhancement of pre-morbid traits and mood swings. And 7, patient can plateau at any stage or regress under conditions of stress or repetitive brain injury. Okay, so I found some pictures for us. So there's actually grades of axonal injury. Axonal injury. According to Adams et al., grade 1, with a grade 1 injury, diffuse axonal injury is present. Hemorrhage in the corpus callosum is absent. Lesions in the dorsolateral rostral brainstem is absent. With a grade 2, the hemorrhage is present, the lesions are absent. And with a grade 3, the hemorrhage and the lesions are present. And this is, let's center that, pictures of a grade 1, 2, and 3. Pretty interesting. And let me show you where I went on this. So here's another classification here. Widespread axonal damage in the white matter of cerebral hemispheres. White matter axonal damage extending to the corpus callosum with shear tissue tear hemorrhages. Pathology of grade 2. With tissue tear hemorrhages in the brainstem. So it looks like grade 1 is just cerebral hemispheres, grade 2 includes the corpus callosum, and then grade 3 includes the brainstem. Duration of coma, brief loss of consciousness, coma of duration, recovery process unclear, immediate coma with posturing and incomplete recovery. Another grading. Cerebral hemispheres, then we add the corpus callosum, and then we add the brainstem. So, varies from mild to profound, may be permanent or temporary. Symptoms may appear immediately or over weeks, months, and years. Clinical signs are loss of consciousness and increased intracranial pressure, deceleration and decortication, and global cerebral edema. So, that's pretty interesting. And I think it mentions those two conditions, which use it or lose it. I can't remember what it is. I'm sure it will be revisited, possibly today, during this lecture. I like that box too. I do. Oh, beautiful. Okay, so let's move on. Examine for general signs of increased intracranial pressure. Examine level of consciousness, Glasgow Coma Scale, cognitive functioning, LOCF. Examine for disorders of learning, attention, memory, and complex information. Examine cranial nerve function. Examine for changes in behavior. Examine for appropriate physical, verbal, sexual behaviors, poor judgment, irritability, low frustration tolerance and aggression, impulsivity and safety issues, depressed mood, unrestricted affect. Examine speech and communication. Examine sensory deficits. Examine motor function. Examine for paresis, apraxia, dyspraxia, reflexive behaviors, balance deficits, ataxia, and incoordination. Cerebellar damage is common. Functional mobility skills, ADLs. Examine level of general conditioning after prolonged hospitalization, comatose, vegetative, decreased response levels. Patients experience severe deconditioning and effects of prolonged immobilization, disuse atrophy, contractures and deformity, and skin breakdown. Examine sympathetic storming, the result of hypothalamic stimulation of the SNS with an increase in circulating corticoids and catecholamines stress response. Examine for alterations on level of consciousness, increasing posturing, dystonia, hypertension, hyperthermia, tachycardia, tachypnea, diaphoresis, and agitation. Patients generally exhibit minimal alertness, minimal awareness, and reflexive motor response to stimulation. Physical therapy goals, outcomes, and intervention. Monitor changes associated with recovery and inactivity. Management based on decreased response level. Maintain range of motion, prevent contracture development, passive range of motion, positioning, splinting, and serial casting. Maintain skin integrity, prevent development of decubitus ulcers through frequent positional changes. Maintain respiratory status, prevent complications, postural, drainage, percussion, vibration, and suctioning to keep airway clear. Provide appropriate stimulation for arousal and to elicit movement and function. Structure environment to enhance alertness and function. Promote early return of FMS, upright positioning for improved arousal, and proper body alignment. Management based on mid-level recovery, LOCF 4 to 6. Provide structure, prevent overstimulation for confused, agitated patient. Close, reduce stimulus environment, daily schedules and memory logs, relaxation techniques. Provide consistency. Use team-determined behavioral modification techniques. Give clear feedback and written contracts. Engage the patient in task-specific training. Limit activities to familiar, well-liked ones. Offer options. Break down complex tasks into component parts. Provide verbal or physical assistance. Control rate of instruction. Provide frequent orientation to time, place, your name, and task. Emphasize safety, behavioral management techniques. Model calm and focused behavior. Management based on high-level recovery, LOCF 7 and 8. Allow for increasing independence. Wean patient from structure, closed to open environments, involve patient in decision-making, assist patient in behavioral, cognitive, emotional reintegration, provide honest feedback, prepare for community reentry, enhance motor learning, and promote independence in functional tasks. FMS, ADLs in real-life environments. Improve postural control, symmetry, and balance. Encourage active lifestyle, improved cardiovascular endurance. Provide emotional support, encourage socialization, behavioral control, and motivation. Reorient and reassure. Provide patient and family education. Okay, so before we get to the signs associated with localized lesions of the cortex, I'm going to pause here for a second. Okay, so we're going to go over that again. Physical therapy goals, outcomes, and interventions. Monitor changes associated with recovery and inactivity. Management based on decreased response level. So we're looking at no response, generalized response, and localized response. You're going to maintain range of motion, prevent contracture development, passive range of motion, positioning, splinting, and ceruloplasty. You're going to maintain skin integrity, prevent development of decubitus ulcers through frequent positional changes. You're going to maintain respiratory status, prevent complications through postural drainage, percussion, vibration, suctioning to keep airway clear. Provide appropriate stimulation for arousal and to elicit movement and function. Structure environment to enhance alertness and function. Promote early return of functional movement skill is pretty much what I think FMS means. Upright positioning for improved arousal and proper body alignment. Okay, so functional mobility skills. Okay. Management based on mid-level recovery, which is the confused. So we got confused agitated, confused inappropriate, and confused appropriate. Provide structure, prevent overstimulation for confused agitated patient. Closed, reduced stimulus environment, daily schedules, memory logs, relaxation techniques. Provide consistency. Use team-determined behavioral modification techniques. Give clear feedback and written contracts. Engage the patient in task-specific training. Limit activities to familiar, well-liked ones. Offer options. Break down complex tasks into component parts. Provide verbal or physical assistance. Control rate of instruction. Provide frequent orientation to time, place, your name, and task. Emphasize safety, behavioral management techniques. Model calm, focused behavior. And then for levels 7 and 8, and you know, when I explained it in part 2, I redid 6 because of the appropriate. I like to group them as response, 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 confused, 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 appropriate, appropriate, appropriate. And that's how I just remember that 6 I put in 2 categories. But for this purpose here, we'll just do 7 and 8, which are the automatic appropriate and purposeful appropriate. Allow for increasing independence. Wean the patient from the structure. Go from a closed to an open environment. Involve patient in decision making. Assist patient in behavioral, cognitive, emotional reintegration. Provide honest feedback and prepare for community reentry. Enhance motor learning and promote independence and functional tasks, functional mobility skills, and ADLs in real-life environments. Provide postural control, symmetry, and balance. Encourage active lifestyle, improved cardiovascular endurance. Provide emotional support. Encourage socialization, behavioral control, and motivation. Reoriented, reorient and reassure, provide patient and family education. Okay, this is table 212. I break it down, but it has the signs associated with localized lesions of the cortex. I'm going to break it down by lobe, frontal, parietal, and temporal, and occipital. See what kind of time we're at. 30 minutes. Okay. Volitional. I did a little bit of vocabulary words because in frontal, the function is discrete volitional movements. Volitional means relating to the use of one's will. Praxis is to organize, plan, and execute motor skills in a refined and efficient manner. Conjugate eye movement to motor coordination of the eyes that allow for bilateral fixation on a single object. To conjugate eye movement is the movement of both eyes in the same direction to maintain binocular gaze. And then aesthetic is just another term for somatosensory. So here's our cerebrum, and as you can see, we have the frontal lobe here, the parietal, the temporal, and the occipital. Here's the parietal, the temporal, and the occipital. Okay, the frontal. Precentral area, primary motor cortex. Premotor area. So the primary, let's see if this gives us all that stuff. Okay, so we are going to go really in depth on these, on this table. So I'm going to, this is the frontal lobe, the precentral area, primary motor cortex. The function is discrete volitional movements. Destructive lesion will cause contralateral paralysis and paresis, most pronounced in distal parts of the lower face. Okay. So here you see the primary cortex, distal part of the limb, the hands, and then the lower part of the face, like the tongue and the mouth. And I found a video that I want to listen to.
You probably recognize your brain as the part of your body that allows you to think, remember, and make decisions. While all those things are true, your brain also does many more things, including allow you to look at the screen to watch this lesson. Scientists now know the brain has several parts responsible for different jobs. From cognitive functioning to muscle control, your brain is the center of action. Advances in technology have allowed scientists to identify different parts of the brain and what they do. They can measure and observe signals your brain sends to different parts of your body, and the reactions your body has to these signals. Signals sent to your muscles all originate in the motor cortex region. The motor cortex region is responsible for all voluntary muscle movements, like taking a drink of water or getting yourself out of bed in the morning. Scientists divide the motor region into three main parts: the primary motor cortex, the supplementary motor cortex, and the premotor cortex. Let's take a close look at the primary motor cortex. Every voluntary movement you make is controlled through the primary motor cortex, or PMC, which is located in the back of the frontal lobe, just about at the top of your head. Signals in your brain are sent to the muscles, telling them to make a movement. For example, sometime after you woke up this morning, you might have thought to yourself, "I need to get up." Without giving it a second thought, a short while later you were standing by your bed and making your next decision of the day. In that brief period of time, your PMC and other parts of your brain were doing a tremendous number of calculations to avoid having you fall in a heap on the floor. Even if you groaned when the alarm went off, you actually made the conscious decision to get out of bed in your prefrontal cortex, the part of your brain responsible for making decisions. The prefrontal cortex sends signals to the premotor cortex, the part of your brain that helps with muscle control. These signals are finally sent to the primary motor cortex, the big boy of this group, responsible for making the muscles move and work together. Imagine your brain having this conversation when you decide to get up in the morning.
What happened? What's happened? Oh no. Well, that kind of sucked. I was all into that video. I was like, yeah. All right, moving on.
The part of the brain that does the job of executing voluntary movements is the motor cortex. The required.
Okay, so we're moving on to the premotor area, which is the function is for motor planning or praxis. Praxis is to organize, plan, and execute motor skills in a refined and efficient manner. A destructive lesion is going to cause apraxia or motor planning difficulties. I like this. For example, one neuron fires when a monkey reaches for a peanut, another will fire when it pulls the lever, and so on. So it's involved in controlling voluntary movement. Let's try to see if we can look at this one without it going black on us.
Are responsible for how smart we are and how well we do in school. Do you ever think about how much else your brain does? Every move you make, from involuntary functions like blinking your eye to voluntary ones like watching this video, is conducted by the brain. Scientists now know that different regions of the brain are responsible for different jobs, from the speech center to the motor center. All regions of the brain are amazing machines that rarely take a break. The premotor cortex is the region we'll focus on in this lesson. Every move the body makes is due to the brain's ability to send signals to the right muscles. All of this happens in a part of the brain called the motor cortex region. The motor cortex has three main parts that each have their own job: the primary motor cortex, the supplementary motor area, and the premotor cortex. The motor region controls all voluntary movements, from planning them to carrying them out. Swinging a baseball bat, typing on the computer, or drinking water are all controlled in the motor cortex region. The premotor cortex is located just in front of the primary motor cortex in the brain. Its job is to prepare the body's muscles for the exact movements they will make. In other words, it helps you control your movements. This morning you got up and dressed. You brushed your teeth and combed your hair. The premotor cortex allowed you to make choices about these movements. You squeezed toothpaste onto your toothbrush and not lotion due to the premotor cortex. It uses information provided by your senses, like seeing the toothpaste tube, to guide decisions. While the motor cortex is...
Oh my goodness. I don't know what's going on with this guy here. Oh well. Okay, so we're going to stay away from that guy's videos. They go black at the end. They sounded really good though. So we're moving on to the prefrontal area of the frontal lobe. The function is motor association area, and a destructive lesion is going to cause loss of specific motor plans. Thinking about thinking. Higher reasoning executive function in the prefrontal cortex. 9 functions of the prefrontal cortex include empathy, insight, response, flexibility, emotion regulation, body regulation, morality, intuition, attuned communication, and fear modulation. So over here we have attention, emotional responses, behavior, and judgment. And this is the prefrontal cortex. So look at this video. Hopefully it won't go black on us.
Planning a party. switching tasks at a moment's notice, suppressing a laugh when one isn't appropriate. These all require the maestro of brain regions, the prefrontal cortex. The prefrontal cortex sits just behind the forehead. It orchestrates complex thought processes much like a maestro conducts a symphony. In the brains of autistic people, though, it doesn't communicate well with other parts of the brain, and it may have an unusual structure. That may be why autistic people often have trouble with making plans, thinking flexibly, or controlling their impulses. Drugs or talk therapy may help to improve the function of this brain area and even, eventually, ease some autism traits.
Okay, so another area in the frontal lobe is the supplementary motor area, often called SMA. The function is bilateral control of posture, and the destructive lesion will cause loss of bilateral control of posture. It responds to sequences of movement and to mental rehearsals of sequences of movement. It's involved in transformation and kinematic to dynamic information. Kinematics, distance and angles that define a movement in space. Dynamic, amounts of force necessary to make a movement. And here it is in the green. So it's right next to the premotor cortex that we've already talked about and the primary motor cortex. And these three areas work together. So let's watch another video.
What role does the supplementary motor area play in movement production? The supplementary motor area is located just anterior to the primary motor cortex. The supplementary motor area does a lot of things, and its true function is not fully clear. But we know, for instance, that it plays a key role in the sequencing of motor actions. Thus, it's involved in producing complex movements. The supplementary motor area also appears to play a big role in bimanual coordination, so when you're working with both hands at the same time. And it also seems to play a role in the generation of internally generated movements. That is, movements that are voluntary in nature and are not in response to a sensory stimulus.
Okay, so moving on to the middle frontal gyrus. Its function is to conjugate eye movements, and a destructive lesion is going to cause transitory paralysis of conjugate eye movements to opposite side. So here's the middle frontal gyrus there, and here's the middle frontal gyrus there in the frontal lobe. Conjugate eye movement means to motor coordination of the eyes that allows for bilateral fixation on a single object. A conjugate eye movement is a movement of both eyes in the same direction to maintain binocular gaze, also referred to as yoked eye movement. Okay, now we're to motor speech area, Broca. It's also in the frontal lobe, the precentral area. The function is language production, and a destructive lesion causes non-fluent aphasia. Aphasia is the condition that robs you of the ability to communicate. It can affect your ability to speak, write, and understand language, both verbal and written. Aphasia typically occurs suddenly after a stroke or a head injury. And that definition was from Mayo Clinic. So here's the Broca's area right here. Here's the Broca's area in the frontal lobe. Here's the primary auditory area right here, motor area, and Wernicke's. Listen to a video.
Welcome to 2-Minute Neuroscience, where I explain neuroscience topics in 2 minutes or less. In this installment, I will discuss Broca's area. Although the anatomical definitions of Broca's area are not completely consistent, it is generally considered to make up some part of a region called the inferior frontal gyrus, which is found in the frontal lobe. In the vast majority of individuals, Broca's area resides in the left cerebral hemisphere. Broca's area was named for the physician Paul Broca, who first identified the region as playing a potentially important role in speech production. Broca based this hypothesis on case studies of patients who had damage to the area and also displayed a deficit of speech. The particular condition Broca observed came to be known as Broca's aphasia and involves a deficit in the ability to produce language. In patients with Broca's aphasia, reading and writing are also often impaired, but language comprehension is typically relatively preserved. The precise role of Broca's area in language production, however, is still being debated. In other words, damage to Broca's area can disrupt language production, but nobody is quite sure exactly what language-related function is lost to cause that disruption. Some have hypothesized Broca's area is involved with producing movements, like of the tongue and mouth, that allow speech to be produced. Others have argued it is involved with syntax, grammar, verbal working memory, or all of the above. Broca's area is also thought to have a variety of other linguistic and non-linguistic functions. It has been recognized as playing an important role in language comprehension, movement, and even understanding the movement or actions of others. Thus, although Broca's area does appear to play a role in language, the overall function seems to be more complex.
Okay.
Welcome to 2-Minute Neuroscience.
Stop that. And let's see, where are we now? So we've done all the precentral area of the frontal lobe, which is the primary motor cortex, the premotor area, the prefrontal area, the supplementary motor, the middle frontal gyrus, and the motor speech area of Broca. So now we're going to do the prefrontal area. So precentral area, prefrontal area. Okay, so now we're still in the frontal lobe, and we're moving to the prefrontal area, which is one of the areas. It's the dorsolateral, and I've broken it up here, dorsolateral in the prefrontal area. Function is motivation and problem solving. Bilateral lesions will cause impaired ability to concentrate. So here's important for directed attention, temporal integration, and working memory. Working memory deficits will cause abstract thinking, less access to memory, less self-reflective consciousness, and less cognitive flexibility. So I found a prefrontal area video that's pretty cool. I'll watch it.
The term prefrontal cortex, or PFC, can be used to refer generally to the part of the frontal lobe that is anterior to or in front of the motor cortex. Neuroscientists generally further divide the PFC into subregions, and while there is no clear consensus on what those subregions should be, some common demarcations include the dorsolateral, dorsomedial, ventrolateral, ventromedial, and orbitofrontal regions. The PFC makes up a substantial proportion of the entire brain, and thus is not surprisingly involved in a long list of functions. But it is most commonly associated with executive functions. There isn't a precise definition for the term executive functions, but it generally refers to processes that focus on controlling short-sighted behavior to be able to act with a goal in mind. This may include things like self-control, planning, decision-making, and problem-solving. Because these are complex cognitive functions, it is unlikely any one brain region is solely responsible for them, and more likely they depend on distributed networks of brain regions. Nevertheless, the PFC seems to play a critically important role in executive functions, a hypothesis supported by neuroimaging research and cases where the PFC was damaged and executive functions impaired. Although each of the subregions of the PFC is typically associated with slightly different aspects of cognition, we are not yet at the point where we can confidently assign specific roles to PFC subregions. Most evidence suggests that the executive functions of the PFC are accomplished due to the interaction of these subregions and their communication with other areas outside the PFC. One general model of PFC function is that it receives sensory information about the external world, uses that information to plan responses, and then communicates with other areas of the brain to enact a response, which might involve anything ranging from movement to simply a redirection of attention. Welcome to 2-Minute Neuro.
Okay, so the next area of the prefrontal area of the frontal lobe is the orbitofrontal area. Its function is emotions and behavior, and a destructive lesion is going to cause unstable emotions and unpredictable behaviors. So here's the orbital frontal cortex right here in the prefrontal area, and it's deals with cognition, judgment, planning, inhibitions, personality, right and wrong, decision making. And I found a pretty cool video. It's kind of out there a little bit, but it also includes the dorsolateral, which we just reviewed previous to the orbital, and it's pretty entertaining. I believe that like real out there educational experiences can help code the information in your brain and help you remember it better. So beware, this video is kind of out there.
So in an overview, first we'll go state of the science, cardiometabolic risks, and then summary. So let's first start with neurobiology.
Oh no, neuroanatomy, that's why we didn't go into neurology.
I've got good news for all of you out there. It ain't that bad, so listen up and get prepared.
The front of the brain is all you need to know. Divided into sections, throw the amygdala for show. The prefrontal cortex is the psych's brain. According to Dr. Stahl, that's more than enough. Bang, bang. What we're gonna do is PET scan people's heads that will give us information that can easily be read. You see, most of the action is up here in the front, and sooner or later, we need to know what's up. So come along and join us in this journey across the sea, a journey that will take you to the DLPFC. Psychiatrist's Bible is the DSM-4. If you open the book, you'll see how symptoms score. Most of the symptoms are in the PFC. Let's count them off and you'll see what we mean. Executive function, attention, emotions, impulses, obsessions, compulsions, motor functions, fatigue, ruminations, worry and pain, guilt, suicide, doubt. Shall we say it again? DLPFC, 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 DLPFC. Stahl says the money is in the front of the brain. It's where the DLPFC likes to play. Information processing, executive functioning. Not knowing how to handle this can really be frustrating. The ventral medial PFC is the front as well. That deals with emotions the patients sometimes tell. Orbital frontal cortex is up there too. Impulsions, obsessions, is anything getting through? So come along and join us in this journey across the sea. A journey that will take you to the DLPFC. DLPFC, 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 DLPFC.
Well, alrighty then. I bet you won't forget that part, right? I ain't doing it. Okay, so let's go back to the PowerPoint. And the next one will be orbital gyri. Alright, so let me pause again. Lots of pausing. Okay, so we're at the last structure in the frontal lobe in the prefrontal area. We have the orbital gyri, posterior lateral. Its function is olfaction, smell, destructive lesion, inability to discriminate odors. Inability to discriminate odors. So there it is in the bottom of the frontal lobe. There it is again, inability to discriminate odors. And I found a short little bitty video, kind of lets you kind of be a little bit better where it is. Yep. Right underneath the eyes, sort of, eye sockets. So that's the ability to discriminate odors, to tell if it's a bad odor or a good odor. Okay. So we are done with the frontal lobe. The next lobe is the temporal lobe. And primary auditory cortex, Wernicke speech area, superior temporal gyrus, left hemisphere, temporal cortex, non-dominant side, and parahippocampal region. So that will be our next area to study temporal lobe. Okay, I realized that I got out of order. The next area is the parietal lobe. The structures are postcentral gyrus, primary somatosensory area, secondary somatosensory area, gustatory cortex, and the parietal lobe right hemisphere. So we're going to do the first line, which is the postcentral gyrus, primary somatosensory area, and its main function is somatosensory sensations, and a destructive lesion is going to cause loss of contralateral stimulus location and intensity. So contralateral stimulus location and intensity. Contralateral stimulus location and intensity. Take a look at this.
Neuroscience, where I simplistically explain neuroscience topics in 2 minutes or less. In this installment, I will discuss the primary somatosensory cortex. The primary somatosensory cortex is located in a ridge of cortex called the postcentral gyrus. It is situated just posterior to the central sulcus, a prominent fissure that runs down the side of the cerebral cortex. The primary somatosensory cortex is responsible for processing somatic sensations, or sensations from the body that include touch, proprioception, or the position of the body in space, nociception, or pain, and temperature. When receptors detect one of these sensations, the information is sent to the thalamus and then to the primary somatosensory cortex. The primary somatosensory cortex is typically divided into 4 areas: Area 3A, 3B, 1, and 2. Area 3 receives the majority of somatosensory input directly from the thalamus, and the initial processing of information occurs here. Area 3B is primarily concerned with basic processing of touch sensations, while Area 3A responds to information from proprioceptors. Area 3B is densely connected to Areas 1 and 2, and when Area 3B receives touch information, that information is then sent to Areas 1 and 2 for more complex processing. Area 2 is also involved with proprioception. Each of the 4 areas of the primary somatosensory cortex is arranged such that a particular location in that area receives information from a particular part of the body. This arrangement is referred to as somatotopic, and the full body is represented in this way in each of the 4 regions of the somatosensory cortex. More sensitive areas of the body take up a disproportionate amount of space in this somatotopic arrangement. Welcome to 2-Minute Neuroscience, where
Okay, that was really quick. Okay, so that was the postcentral gyrus, primary somatosensory. The next area would be secondary somatosensory area. The function is sensory interpretation. And then destructive lesion is going to cause tactile, agnosia, asterognosis, agraphesthesia, loss of 2-point discrimination, and extinction. Okay, so the parietal lobe has the secondary somatosensory area. Function is sensory interpretation. A destructive lesion is going to cause tactile agnosia, asterognosis, agraphesthesia, loss of 2-point discrimination, and extinction. Agnosia, inability to recognize incoming information despite intact sensory capabilities. Can include visual object agnosia, auditory agnosia, or tactile agnosia, which is asterognosis. Proximal and distal locations on the same side of the body. Proximal and distal locations on the same side of the body. The term distinction phenomenon is used to describe a situation in which only the proximal stimulus is perceived with extinction of the distal. Agraphesthesia is a disorder of directional cutaneous kinesthesia, or a disorientation of the skin sensation across its space. It is a difficulty recognizing a written number or letter traced on the skin after parietal damage. Okay. So, where are we now? Moving on to gustatory cortex. Function is taste. A destructive lesion is going to cause impairment of taste in contralateral side of tongue. Okay, so gustatory cortex. Function is taste. Impairment of taste in contralateral side of the tongue.
Welcome to 2-Minute Neuroscience, where I explain neuroscience topics in 2 minutes or less. In this installment, I will discuss taste. The tongue is covered with many little bumps, which are sometimes mistakenly called taste buds. These small lumps of tissue, however, are known as papillae. Taste buds are found in the walls of papillae and the grooves surrounding them. Each taste bud contains anywhere from 50 to 150 taste receptor cells. Extending from these cells are fine microvilli, sometimes called taste hairs or gustatory hairs, which protrude through an opening called the taste pore into the mouth. These microvilli come in contact with substances in the mouth that can be tasted, also known as tastins. Tastins interact with taste receptor cells through a number of different mechanisms to depolarize the cells. When taste cells are depolarized, they release neurotransmitters that stimulate sensory neurons that travel in cranial nerves 7, 9, and 10. These neurons terminate on neurons in the nucleus of the solitary tract in the medulla. From there, taste information is sent to the thalamus. Then, taste information is sent to the gustatory cortex, which is a region of the cerebral cortex found along the border between the anterior insula and a structure called the frontal operculum. The gustatory cortex allows us to consciously discriminate different taste stimuli. The taste information sent along these pathways is thought to encode for basic tastes, such as sweet, salty, sour, bitter, and savory or umami. Whether there are others is still being debated. However, the actual flavor of a food, which is what we typically define as taste, is created by a combination of taste and olfactory information.
Okay, so what's next? Parietal lobe, right hemisphere. Function, perceptual function. Obstructive lesion, visual spatial disorders, body scheme disorders, apraxias, tactile and auditory perceptual disorders. Okay, parietal lobe, right hemisphere. Function is perceptual and a destructive lesion. You're going to see visual spatial disorders, body scheme disorders, apraxias, tactile and auditory perceptual disorders. Remember, praxis is to organize, plan, and execute motor skills in a refined and efficient manner. Apraxia, disorders of skilled movement, not caused by weakness, deafferentation, abnormality of tone or posture, abnormal movements, intellectual deterioration, poor comprehension, or uncooperativeness. Over here we have topographic disorientation, topographic memory loss, agnosia, dressing apraxia, constructional apraxia, hemi-inattention apraxia of eye opening and confusion. So topographical corresponds between the skin and the cortex. Motor, I got this out of the, this information was out of the neuroscience book. Ebook. Apraxia can be considered motor agnosia. The knowledge of how to perform skilled movement is lost. In apraxia, a person is unable to perform a movement or a sequence of movements despite intact sensation, normal muscle strength, and coordination and understanding of the task. An example is brushing one's teeth with a dry toothbrush, then putting toothpaste on the brush. Another example is putting socks on over shoes. Apraxia occurs as a result of damage to the premotor or supplementary motor areas or the inferior parietal lobe. A subtype of apraxia, constructional apraxia, refers to the ability to comprehend the relationship, interferes with the ability to comprehend the relationship of parts of the whole. This deficit impairs the ability to draw and to arrange objects correctly in space. Same book, adults with parietal lobe damage have abnormal timing of reaching and grasp, lack anticipatory adjustments of the fingers, and use palmar rather than pincer grasp. Pincer grasp requires corticospinal control. The lack of proprioceptive input to the corticospinal tract explains why adults with parietal lobe damage use the palmar grasp. Infants use the palmar grasp before myelination of the corticospinal tract is complete. inability to use visual information. So a woman with damage in the parietal lobe will be unable to adjust her reach and hand orientation appropriately to the size and shape of objects. Yet she will be able to describe and visually identify the object. The optopic ataxia does not affect the ability to consciously perceive visual information. And over here on the other side, asymmetry in the drawing of a person, for example, omitting part of the left side of the body or providing less detail on the left side of the body, indicates neglect associated with damage to the right parietal lobe. So perceptual, I cannot talk today. Perceptual function, visual spatial disorders, body scheme disorders, apraxias, tactile and auditory perceptual disorders. Right hemisphere of the parietal lobe. Okay, where are we? And so the parietal lobe is now done. So now we are at the temporal lobe, and we got temporal lobe to go. And let's see. Occipital lobe. And then levels of traumatic brain injury. And then we are done, and I can go eat lunch. I think I need some sushi today. After all this, I need a break. Okay, so temporal lobe. And please hold. Okay, so I'm getting kind of tired of this. So I'm going to wrap this up. Temporal lobe, primary auditory cortex. Function is for hearing. Destructive lesion, subtle decrease in hearing, and ability to localize sounds, both contralaterally. Wernicke speech area, language understanding and formulation. A destructive lesion is going to cause fluent aphasia. Superior temporal gyrus, left hemisphere, storage of auditorily presented information, cause impairment of learning and memory. That's all mixed up. I they didn't separate it correctly or something. Anyway, temporal cortex, non-dominant side, storage of visually presented information, profound memory loss of recent events, no new learning. Parahippocampal region is recent memory. A destructive lesion, no new learning. Parahippocampal region, function, recent memory, destructive lesion, no new learning. That's where I divided it. Occipital, primary cortex, primary visual cortex, function is vision, destructive lesion, contralateral, homologous hemianopsia, impairment of vision, visual association cortex, visual understanding, visual agnosia, posterior multimodal area, the parietal, occipital, and temporal lobes integrate sensory information, somatosensory, visual, and auditory. Perceptual impairment is a destructive lesion. I want to go back and get a definition of this right here. So let's hold on that for just a second. Okay, I'm wrapping this up. So, contralateral, this word, a view of Paris for someone with it, a view of Paris with normal vision. Okay? Visual agnosia, not able to not able to name and function of a seen object, either by spoken, written words, or by gesture. Visual acuity is intact and not aphasic. Can identify the object by palpation, smell, or sound, if presented in other sensory modality. So, a patient might think that this is a coconut when it's an acorn, might think this is a spider when it's actually a octopus, think this pretzel is a snake, this octopus is a bug, this mushroom is a lamp. Okay, last slide. Table 213, levels of traumatic brain injury. And I think we already went through this. Loss of consciousness, 0 to 30 minutes. Mild TBI, alteration of consciousness. Brief, 24 hours, less than 24 hours. Post-traumatic amnesia, which is PTA, is less than a day. Glasgow Coma Scale is 13 to 15. Imaging is normal. Moderate TBI, loss of consciousness, 30 minutes, but more than 30 minutes, but less than 24 hours. Alteration of consciousness is less than 24 hours. Post-traumatic amnesia, more than 1 day, but less than 7 days. Glasgow Coma Scale, 9 to 12. Imaging is normal or abnormal. Severe TBI is greater than 24 hours. Alteration of consciousness, greater than 24 hours. Post-traumatic amnesia, greater than 7 days. Glasgow Coma Scale, less than 9. And imaging is normal or abnormal. And that is going to wrap up TBI. Yay!